Welcome to the latest series of the podcast Medical Evidence Matters with me, Liz Tucker, the podcast aimed at doctors and patients. It was formerly known as What Your GP Doesn't Tell You. In this opening episode of the series, I'm talking to Dr. Nina Fuller-Shavel, who has a particular interest in integrative oncology and the use of injectable mistletoe as a supportive cancer treatment in conjunction with the standard treatments such as chemotherapy, radiotherapy, and immunotherapy. I've been keen to get Nina on the podcast ever since I heard her speak at the Integrative and Personalised Medicine Congress earlier this year in London. Nina was working as a doctor in the UK's NHS when she discovered in her early 30s that she had breast cancer. That was a decade ago, but that experience and her treatment helped focus her mind on the reality of being a cancer patient and of the importance of treating the whole person, not just the disease. Injectable mistletoe therapy is used widely in hospitals in Germany, with up to 60% of patients using it in their cancer care, but it's rarely used in the UK or the States. Yet results and published data suggest it can help a patient's fatigue, general quality of life, and may even be able to improve white cell count, which could be critically important for chemotherapy patients who sometimes have to delay further treatment if their therapy causes their white cell count to drop too low. Nina has now had patients who've been on the treatment for years, and she's keen to persuade the British authorities to adopt it as a recommended, cost-effective cancer treatment. But before we get to Nina's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com/whatyourgpdoesn'ttellyu or via PayPal on my website, whatyourgpdoesn'ttellyu.com. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. Now back to Nina's interview. Dr. Nina Fuller-Shavel. Dr. Nina Fuller-Shavel did her medical training at the University of Cambridge. Amongst her qualifications, she holds an MSc with distinction in precision cancer medicine from Oxford. In addition, she's a fellow of the College of Medicine and the British Association for Nutrition and Lifestyle Medicine. She is also the director of the Synthesis Clinic, CEO of the UK National Centre for Integrative Oncology, and co-founder and director of ONCIA, CIC, a non-profit aimed at providing app-based resources for people with cancer and supporting best clinical practice and research in integrative oncology. Here's Nina's interview. So Nina, thanks so much for joining the podcast today.
Lovely to be here. Thank you.
Now, Nina, you're a trained medical doctor and you describe yourself as an integrative medicine doctor. What exactly does that mean?
So it means that I'm conventionally trained as anybody else in the medical profession, but I also bring other elements of the toolkit with it. So, for example, alongside my 2 degrees in natural sciences and medicine from Cambridge and Masters in Precision Cancer Medicine and PG Dip in Health Research from Oxford, I also have qualifications in nutrition, traditional Chinese medicine, yoga, and a number of other qualifications from health coaching to integrative medicine and functional medicine. So the idea is that really I am still a doctor, I'm a prescriber, I'm a diagnostician, but I also look much more broadly and I don't only have medication, surgery, and other treatments to be able to pick from, but I also look at the whole person.
So how would you define the difference between standard oncological medicine and integrative oncology?
So I would say with integrative oncology, we're really looking at a broader aspect beyond just standard conventional care. So standard oncological medicine is something we should absolutely do as a part of integrative oncology. And in addition to this, we're also looking at things like lifestyle modifications. We're looking at mind-body therapies, look at evidence-based complementary care, natural products. So the idea is that you really have a broader toolkit to draw from. And the aim of integrative oncology is also really, really important because here we're not aiming just to focus on the tumor. We're focusing on the whole patient. So here the aim is very much to promote whole patient resilience, to support their quality of life, to minimize symptom burden, and really optimize clinical outcomes for that person.
And I'm interested, Nina, what drove you to this wider perspective? Was it your own experience as a cancer patient, do you think, or was it just part of your worldview anyway?
I think it was part of my worldview anyway. I mean, I actually encountered herbal medicine when my grandmother started using it when I was a child. So I've kind of grown up with different ways of, fresh whole foods. We used to have our own orchard and we used to be able to run around and just eat fresh food. So nutrition, exercise, nature, herbal medicine were always a part of my upbringing. So I think I've always had that lens. And then I think specific focus on integrative oncology very much came post my diagnosis. I think I had a very rosy view of it as an internal medicine doctor, of thinking, oh, once I've gotten my patient, I pass them on to oncology, surely they're going to get better care and some advice and some support. And then I became a patient. I was like, oh my goodness, nobody gets asked the right questions. Nobody is asked about their nutrition, whether they move, who's supporting them at home, how might their diagnosis have impacted them and their ecosystem and their family. Are they sleeping at all, actually? And what else are they using? So I think it's really, really important that we ask those questions. And I think my worldview just kind of grew more specific and to focus on integrative oncology over time.
So how did you first become interested in mistletoe as a potential cancer treatment?
Oh, good question, actually. I think is a part of the whole integrative oncology journey, really. So I had my own breast cancer at 33. So I've gone through my own standard of care treatment. And I still remember saying to my oncologist at 33 with a young child on my hand saying, you nuke me and I'll do everything I need to do to keep myself well throughout it. And so I didn't use mistletoe during my own treatment because I wasn't actually far enough in my own education. Also, I couldn't prescribe for myself. And there weren't very many mistletoe clinics available, actually, at that time. But when I completed treatment, I started looking at getting more integrative oncology education. Then I came across mistletoe therapy and the significant evidence base it had behind it and its use in Germany, Austria, and Switzerland in particular, in terms of being aligned with conventional care and being given in acute medicine hospitals on oncology wards during standard oncological outpatient care. And that's really what piqued my interest because I thought, well, actually, if up to 60% of patients in Germany receive mistletoe treatment during standard oncological care, why is it not available in the UK? And actually, what does it offer patients that we should be offering to our patients in the UK? And that's really what piqued my interest and started that whole education.
And we should be clear, this has got nothing to do with the homeopathic use of mistletoe.
No, when we think about mistletoe therapy in this particular instance, this is all injectable mistletoe therapy. So it will come from defined manufacturers who are actually pretty much pharmaceutical companies. And it will be an injectable ampule that you will use usually subcutaneously on license in places like Germany, Austria, and Switzerland, and some of the other international countries. Usually it's injected 2 to 3 times a week. And then there's various off-label uses, such as intravenous use as well. With oral homeopathic drops, this is not what has been studied and what has been incorporated into the guidelines.
So it's puzzling. I mean, Germany is a respected country in terms of medical research. So why do you think it hasn't been more widely adopted in countries like the UK?
I think a lot of it comes from its heritage, really. Mistletoe therapy is a part of the anthroposophical medicine tradition, and that's actually the original use of mistletoe as a cancer supportive treatment has come from Rudolf Steiner's work back in the 1900s, really. And actually, Germany kind of ran with it, and all the German-speaking countries sort of by return ran with it as well. Now, we are probably not fantastic at reading other people's literature in German anyway. Lots of us don't want to dive into something and translate it. But also, I think that UK has changed its kind of, I guess, positioning as well, according to what we are happy to adopt and translate across different borders. So I don't think that's helped either. But I find it really interesting that in Germany, you can have mistletoe therapy approved and reimbursed on insurance for patients with advanced solid tumors across all of their different treatments. Yet we cannot get it on license subcutaneously for any patients at the moment. Now, I'm on a bit of a mission to change that, and I'm hoping that actually by having some sensible discussions with MHRA around the fact that the standard of evidence for a supportive care treatment shouldn't be different between different countries, and submitting a dossier of information will help us in the future to get licensing in this country. But yeah, I do find it a bit silly, really.
Yeah, so you're suggesting that because research papers about mistletoe tend to be written in German, sadly, both the UK and the US, probably two of the countries with the worst reputation for learning other people's languages, hasn't really helped.
Yeah, it hasn't helped. I mean, we now have plenty of English language literature as well. But as we know, unless it's actually taught to you in medical school as a part of your training, it's embedded into your medical system. That is not something you're going to go and find out about. So now you can go out and you can get, easily 20 different studies on quality of life and mistletoe therapy in English. But if you can imagine, of course, we've all been trained in a system that doesn't use it all the time. Whereas in Germany, it's something that's part of the parlance. In fact, what was interesting, I was talking to one of the German oncology physicians, and he was saying it's a nightmare trying to recruit for mistletoe trials because nobody wants to be in the placebo group. People will actually refuse to be in a trial if they know they might be put in the placebo group because it's such a part of kind of their standard of care effectively. So I think we've got a language issue, we've got a medical culture issue, which I think is another problem. And I think the fact that we just need to be a little bit more open and looking outside the box and looking to other medical systems, because our cancer outcomes are not fantastic compared to the money that we spend on cancer treatment.
And you're saying it's 60% of patients in a German hospital would have mistletoe therapy. So it's not a small number of people. It's the majority of patients in Germany having cancer treatment will have mistletoe therapy, which presumably means there must be an awful lot of data about it.
Exactly. And that's actually, we are in different phases of mistletoe research in different countries. So in Germany, we're in post-marketing surveillance. It's an approved and licensed product, and they've set up a post-marketing surveillance registry called the Network Oncology Registry. And there have been a number of different papers over the years, all available in English. They've been published by Professor Schad and Anja Thronike and a number of other colleagues that you can look at. And they've been looking at everything from safety in combination with immunotherapy, with targeted therapies. They're looking at quality of life. They're looking at some of the survival outcomes. Obviously, registry data has its caveats. It's not perfect, but they do have really robust, high numbers for a number of crucial questions that we have.
And when you say registry data, you mean people reporting back after the event?
Yeah, so there's clinicians actually will put into it, as soon as they initiate somebody on mistletoe therapy, they will actually start putting in the data into the registry. So it's not just after the fact, it's actually as they initiate treatment, they will have data points that will contribute to that bit. So that's really, really important because we're looking at hundreds of patients across Germany.
And what about other German-speaking countries such as Switzerland?
Good questions. From what I understand, they don't have a well set up registry, but I think they're working on it. So last time I spoke to my Swiss colleagues, they were working on trying to set up something similar to that. So I think that's up and coming. So probably in the next couple of years, we will have that. But I haven't seen any Swiss registry data being published so far.
And what sort of reaction do you get from your British and American colleagues when you talk about this?
So I think it very much depends on how you talk about it. From my side of things, I think it's really important to be clear on the mechanism, on what you're trying to do, and not overstate the evidence. So I think there've been some really wild claims out there in the community about what mistletoe can and can't do. So I want to be very clear that mistletoe is a supportive care medication. Okay, that's what it's designed to do. It's designed to support people on conventional treatments in getting through their treatment with good quality of life, with less fatigue, with better symptom control.
It's not some miracle cure.
It is not a miracle cure. I would love to have a miracle cure at the tips of my fingers. But as we know, cancer is complex, and as a complex problem, it requires a complex intervention. So mistletoe is a part of my toolkit, but it is absolutely not the whole of my toolkit. So I think when I talk to US physicians and UK physicians, it's very much more about saying, okay, this is how we position it. It's a supportive care medication. It can help your patients get better quality of life and less fatigue on treatment. It may be able to support some of the white cell counts depending on the treatment that they're on. We certainly find that it really can help with tolerance and dose maintenance of treatments. If you're interested in keeping your patients on standard oncological side, then it's really, really important that we consider it. Of course, it has to be done by an experienced physician as well. This is an injectable medication. This isn't a self-administered something out there. So we do need to make sure it's prescribed and monitored and adjusted appropriately by someone who knows what they're doing.
And as with all my guests, can I ask you, as proponent of mistletoe therapy, what your financial interests are in the area?
So from my side of things, I do speak for Helixor for educational events. Now, I don't receive any honoraria from them, but they do provide free products to our patients for low-cost mistletoe access, and they donate to integrative oncology charities on my behalf instead of an honorarium. They'll occasionally cover my travel expenses.
And this is the manufacturer of the particular mistletoe that you use?
Correct, yes. Well, so I use three. So I will use Iscador, Helixor, and Abnoba viscum, so I'm not really aligned to one particular kind.
Okay, so there are 3 types of mistletoe you use. Can you explain what the different species are?
So the species itself is actually the same species. So we use Viscum album linnaeus. So that's a white berry European mistletoe. But in terms of how it behaves, it very much depends on processing of the plant, the collection of the plant, and where does this mistletoe as a parasitic plant grow. Because if it grows on different trees, it will actually acquire different constituents within its phytochemistry. So when we're looking at mistletoe that grows on fir, so Ibietes, like Helixor A, for example, we're looking at apple, Mali, or M. We can look at peony, P, and Quercus as oak as Q. They're the 4 most common kinds of trees you can see, although we use things like ash as well and many other trees. But out of all these 4 trees, depending on which tree the mistletoe grows on, it will acquire different composition. And then in and of itself, the processing of that mistletoe, whether it's fermented, unfermented, how it's actually created, that product will also contain different phytochemical compounds. So what we're looking at is really very, very much personalized sub-medicines within the overall mistletoe category. So you need to know your brand and how it's processed, but you also need to know the host tree and how you apply it to the patient.
How fascinating. So somehow the tree that the mistletoe grows on affects its biological properties because it's a parasitic reaction, effectively.
Yeah, exactly. So actually, because we're thinking about it, different trees will have different components to them, different tannins, different compounds. So it's probably not surprising that if you put a parasite on one host tree versus another, you will get a different phytochemical composition. And you also get peaks of the different compounds through the seasons as well. So a lot of the time you will find mistletoe manufacturers will collect at least a winter and a summer harvest, and then occasionally 4 harvests a year to make sure they're getting all of the active compounds in a really nice concentration.
And depending on what sort of cancer someone has will affect the type of mistletoe therapy that you offer them.
Absolutely, but also it's personalized to patient as well. So when we're looking at which kind of mistletoe we want to prescribe and what host tree we want to use, we are looking at both patient factors and tumor-related factors.
Can you break down a little bit what those patient factors might be?
So first things first is things like atopy. If somebody has an atopic constitution, they've had maybe quite a few allergies in the past, we will be quite cautious. We might be going for Ibietes, a fir-type mistletoe. And that's because it tends to be a lot less lectin-rich, and lectins tend to be much more immunostimulatory. They tend to push the immune systems a little bit more. And because it's slightly more anti-inflammatory, we find that's usually a good introductory mistletoe. If somebody is really debilitated as well, or if somebody is maybe on intensive chemotherapy, that's something you might want to start with. If you've got somebody who's got a robust constitution, then again, you're going to be going for a slightly different kind of mistletoe. So you're looking at somebody's medical history and somebody's current presentation.
So let's take, for example, breast cancer. How would breast cancer come into the mix in terms of what particular therapy you might choose?
So you picked actually one of the more complicated questions, so which is great, actually. It's a good illustration because this is where, if I took Helixor as one example, A, M, or P, right? I could actually use any one of those in a different situation. So imagine if I have somebody who's really quite deconditioned and is about to hit her first chemotherapy, and maybe she's got some asthma or eczema. I would be starting with Helixor A in that particular situation. And that's because that would suit the situation very well, despite the fact that she's got breast cancer. Now, if we're looking at specifically tumor type, we're looking at really Helixor M in terms of the balance between the lectins and viscotoxins, etc. However, for that debilitated patients just about to hit chemo, I'm not going to be using M straight away. I might be starting with A and then eventually converting her to M because that's a more appropriate mistletoe for her tumor type. Another thing we need to consider, if I've got a patient who has brain metastases from their breast cancer, I would pick a different kind of mistletoe as well. So again, all of that clinical situation is important. If I have somebody who maybe has had mistletoe before, such as Helixor, and progressed on it with metastatic disease, we will be looking to switch up to Helix or P, actually. So I can actually use anything, but that very much dynamic decision-making will depend on what the patient is doing right now and not just a tumor type.
So how many options have you got when you're looking at the different mistletoe therapies that you can offer?
Many. So you've got 3 common brands that we use in the UK. So there's 4 that are probably used in most German-speaking countries. But for us, we've got Helixor, we've got Iscador and Abnobaviscum. Within each of those, there's multiple different host tree types. So for example, Abnobaviscum has more than the 3. So Helixor has A, M, and P. Then you've got Iscador that has 5 different host trees, and Abnobaviscum has even more. So we have many, many, many options. And the trained clinician will know which particular kind of mistletoe to use in a particular kind of situation.
So it's interesting, the one plant can have such a different impact on the disease.
Absolutely. And I think what's interesting about it is because of the host tree influences and because of how it's processed, like fermented versus non-fermented mistletoe has quite a different impact on the immune system. So having fermented extracts such as Iscador is different to Helixor because what they tend to do, they carry a lot of LPS with them. So it's a very immunostimulatory, but can also cause quite a big reaction, quite a bit of side effects with it.
And can you explain what LPS is?
LPS is lipopolysaccharide. So because it's fermented, it will have some bacterial material in it that will cause an immunostimulant, like an adjuvant effect, effectively. So mistletoe in and of itself is an immunomodulator with an immunostimulant lean. So if you add some fermentation on top of that, you're going to get quite a big punchy preparation, really. So you need to use it wisely. It's not going to be appropriate necessarily for everybody. So you need to make sure that you know what you're doing with type and host tree and the patient in front of you. And we need to be constantly monitoring them because how one person's immune system responds to treatment is going to be very different to another. People ask me, what's the target dose? And I'm like, you don't really have a target dose because your immune system and my list might be completely different. I'll give you Helixor A 5 milligrams and you might have no reaction. And I might have a good 2 centimeter skin reaction that tells me I'm getting an optimum response. So it's a very personalized, tailored therapy that you really change dynamically.
So for me, for example, if I had the smallest mosquito bite, my skin always flares up in the most spectacular fashion.
Yeah, so for you, Helixor A would be actually the first, and I would escalate that a lot slower than maybe as on a standard protocol because I'd want to make sure you get the minimal side effects. I might also suggest co-medicating with desloratadine because depending on what kind of tumor type somebody might have, there's also some really interesting data around how antihistamines can potentially influence the broader cancer picture as well.
So you mentioned antihistamines having an impact. How does that fit in?
So for us, it's quite an interesting one. So we use it, usually we use things like desloratadine, so H1 antihistamines, as an adjunctive treatment to mistletoe for people who really suffer with the itchiness. So we use it very much on license for antihistamine effects. However, there is some very early data, observational data from actually pretty big cohorts. I think the Swedish cohort was in the tens of thousands that look at use of antihistamines and outcomes with different solid tumors. And what we are finding is with antihistamine use in immunogenic tumors, we actually have that associated with significantly better overall survival. Now, there's some mechanistic data around this to say actually histamine in a tumor microenvironment it's not great. It's actually immunosuppressive to the correct anti-tumor response, and it promotes a wrong polarization, wrong shift in the tumor microenvironment. So your own immune system doesn't work very well. So having an antihistamine was really interesting as we are now thinking from preliminary research, it shifts that environment and allows your own immune system to come to the fore more. So we haven't really done combination studies in mistletoe and desloratadine specifically, and I think somebody should definitely do this work. But what we are doing at the moment is combining those 2 data sets together and say, actually, we're just giving it to you on license for antihistamine control. If there might be some potential evidence for overall survival impact, great, then fantastic. But it's really registry kind of data, observational data with about actually 40% impact on some immunogenic cancers in terms of OS, so not a trivial number.
So presumably, if it isn't a factor, it's some sort of anti-inflammatory.
Yeah. Anti-inflammatory is probably broader than histamine. I think we need to bring it down to the Th2 pathway very much more specifically. It is anti-Th2. So therefore, you're actually looking at relieving the immunosuppression in the tumor microenvironment by reducing the amount of histamine and polarization. So it's like a seesaw, I would say. We have either an effective immune response on one side and an ineffective one on the other side. And usually tumors that have been allowed to develop and grow for a long time, like solid tumors, would have evaded immune detection, immune killing for a long, long time. So if we are able to give an effective treatment, standard of care, plus an effective immune supporter, plus potentially a modulator of the tumor microenvironment, we might have an interesting impact there.
Slightly sort of by the way, but I remember a while back reading a study in breast cancer, and they'd given anti-inflammatories to patients before breast cancer surgery, and it was reporting a lower recurrence rate.
There's, I think, been a few studies like that. Looking at NSAIDs in particular, of course, NSAIDs in of themselves are possibly not the best intervention in the world for multiple different risk reasons. So there have been a few studies on that. I think we know that surgery in and of itself is, of course, a massively pro-inflammatory stressor. We also have really interesting data that actually, going back to mistletoe, that surgery-induced immunosuppression that can happen post-surgery, that viscum could potentially relieve that. So again, early data, I think we've had a single study on that, but it'd be really interesting to see in the future if we could actually say, does it have a bit of an anti-inflammatory reaction? Because apart from an immunostimulant lean, it has some balancing compounds. It's a very, very clever plant where it has some triterpenes and it has some of the other compounds that kind of balance out the immunostimulant side. But what I would say is I think we understand that surgery is a massive pro-inflammatory stimulus. Inflammation is one of the tumor hallmarks, right? It's one of the hallmarks of cancer. We know that engendering massive and uncontrolled inflammation is a significant problem from point of view of primary cancer risk, such as inflammatory bowel disease, and colorectal cancer. We also know that it's a facilitator. And this is why it's so important, actually, that we really understand our patient's systemic inflammatory markers. I really do monitor that throughout treatment because having uncontrolled inflammation that we're not doing anything about is a problem. And it's been associated with a number of different prospective studies with poorer outcomes having uncontrolled systemic inflammation. So I would say, are NSAIDs pre-surgery the answer? We don't know. Equally think I'd like us to look at a broader toolkit. There are a number of other anti-inflammatory agents we could give before surgery to modulate inflammation. So I think it's a work that kind of got stuck a little bit and didn't really go into clinical practice.
So certainly things like CRP are important markers to look at before a patient has their treatment.
Absolutely. So usually we monitor CRP, C-reactive protein, ESR, erythrocyte, sedimentation rate, and ferritin as a part of an iron profile, full stop, because all three of those are really important. And sometimes if you just look at CRP, you will miss out the chronic pathway inflammation that upregulates ESR preferentially. So you do need to look at a broader picture. You can't just use CRP as one marker.
And is there anyone who wouldn't be a candidate for mistletoe therapy?
Absolutely. There's always cautions and contraindications, as you know, to every single medicine we have. So from our perspective, I mean, the absolute contraindication would be having had a proper allergic episode with mistletoe before. It doesn't mean a pseudo allergy. So you can get allergic type reactions that are not an actual real allergy with mistletoe. And a trained clinician knows it, understands it, is able to manage that. But if you had proper allergy to mistletoe, you wouldn't be able to have that. There's some pregnancy, of course, and lactation. We don't have any data on that, so that's not something we'd be able to offer patients. And then there are some more temporary contraindications. So people who are in acute hyperthyroidism, so very much, tachycardic, thyrotoxicosis patients, we wouldn't be able to put that in. People who are having an acute flare of their inflammatory disease, for example, any autoimmune diseases, we'd wait until it's controlled. And then some other things like if you've got cerebral edema from either brain mets or a primary brain tumor, you wouldn't want to do it. Or same thing with the spinal cord. So if there's any CNS edema, you really would not be starting mistletoe therapy. Now, it's not a contraindication later on, for example. So if you've had a brain met that's been fully treated and you don't have any edema on your MRI, then it means we could potentially start with a helixoate at low doses and very carefully monitor you and progress from there. But in terms of cerebral edema, that would be an absolute contraindication. We would stop mistletoe and wait until the patient recovers.
Now, you mentioned that you give it subcutaneously. What's the benefit of giving the mistletoe in that way?
So subcutaneously, we are really looking very specifically at immunomodulation effects. Because it's injected away from the site of the tumor, what we are looking for is actually support for the immune system. So you're looking at quality of life, fatigue, and immune support, really.
And what does the data show in terms of improvement in fatigue and quality of life measures?
So with fatigue and quality of life measures, I would say the strongest evidence is for quality of life. And in fact, if we're looking at the German S3 guideline, which is their main kind of guideline on the use of different complementary therapies, it's actually recommended as a treatment for quality of life support for patients with all solid tumors on conventional cancer treatment. So there's a really broad recommendation there. And they actually put it down as a level of evidence of 1A.
If you could just explain what 1A means as level of evidence.
Of course. So that's a high level of evidence. In fact, it's some of the highest. So it means there's been multiple studies that show an impact on quality of life of patients across different solid tumor types. There's also some sub-guidelines. So the breast cancer guideline, for example, the gynecological cancer guideline supports its use during radiotherapy. There's a few other guidelines per specific tumor type that also support its use. So for quality of life, we have really good guideline recommendations. We also have a international guideline recommendation. That's an SIO 2017 guideline for breast cancer that put it as a may recommend for quality of life support. So they put it at that time, which was a few years ago, as a grade C evidence for that in breast cancer specifically. Now, for fatigue, the quality of the evidence is not as good. So we definitely find that most of the time when people looked at it, it's been a subscale of a quality of life study. So the evidence is variable. We do, however, find if you actually analyze all of the evidence, most systematic reviews and meta-analysis have found an impact. And it's a moderate size, clinically relevant impact on fatigue that's probably comparable to the effect of exercise. And of course, in clinical practice, I'd like to use both.
So what comes into the quality of life measure? You mentioned exercise, but what would be the other factors?
So with quality of life, it depends on the score that you use. You're really looking at the impact of symptoms on your kind of daily function, really. And it might be anything from physical impairments to mental health impairments. So it depends on the scale that you use, really, in terms of what questions and what dimensions and domains they will measure.
But is that tricky? Because quite often those quality of life measures can be quite subjective.
Absolutely. And here, what we are looking at is really the changes for you from that perspective. Does it improve your quality of life? And actually, I would say here, the individual variation is really, really important. You're absolutely right. I think anything to do with symptom scores or patient report outcome measures, what I might rate as 3, another person might rate as 7. So I think it's really, really important that when we're looking at this data, we are looking at the person's baseline and then where do they go from that baseline.
So, for example, with chemotherapy, one of the commonly reported symptoms is nausea. Does mistletoe help with that?
So interesting enough, there is some data on that. I have to say it is not used as an antiemetic in my own clinical practice. I find that there's much more effective things we can use, so acupuncture being one of them. So I think the evidence is much stronger for acupuncture and chemotherapy-induced nausea and vomiting than it is for mistletoe. But there have been a couple of studies that show that pain and nausea have been improved.
Now, earlier on in the interview, you also mentioned that mistletoe therapy can play a role in improving white cell count. How much do we know about that?
Not masses, I have to say. So what we do know is that certainly in healthy volunteers, they've done a study where we can see that it improves the white cell counts overall and it improves granulocyte counts. So neutrophils in particular have been helped, and something called GM-CSF. And that's really a growth factor for some of the granulocytes. So we have this. We also know there's a trend towards improved white cell counts, a number of studies of patients with cancer. I don't think anybody's done a really robust analysis, so I think that's something we really need to wait for, and certainly something that I am planning to do in the next couple of years. We're actually planning a phase 2 study looking at CDK4/6 inhibitors, which are therapies that are used in breast cancer that really suppress your white cell counts, and using mistletoe alongside those to support them. And that's because, based on clinical experience, because we use it a lot with conventional treatments, we certainly find that we can reduce cytopenias.
Because certainly for a number of patients, their white cells take a huge hit during things like chemotherapy, for example. And you've been talking about mistletoe therapy as a supportive therapy. But if the data suggested it had a major impact on white cell count, that would be rather more than supportive therapy.
True. I still think it really is there to support the chemotherapeutic effect. I think it's a synergistic effect, and I think that's really important.
Sure. But I'm just thinking, for example, I can remember when a relative of mine was having it for breast cancer. A couple of times her white cell count was too low. So you've then got to wait for the treatment. Whereas if the mistletoe keeps your white cell count up, it might make the chemotherapy faster and perhaps more efficient.
Exactly. So it allows us to maintain what we call RDI, relative dose intensity, which is really important. So we want to maintain the chemotherapeutic intensity because that's the stuff that's actually going to make impact from that side. We also want to reduce the impact of infection, right? Because that's actually a major source of morbidity and mortality for patients with cancer. So from my side, I generally see, and again, this is data we're looking at and we're looking at publishing over the next year or two, but in our own mistletoe audit, we see that we can reduce even things like GCSF count support, which is an injectable pro-neutrophil intervention, but can give really significant side effects. So it gets given to patients with chemotherapy. But if you have 3 to 5 injections, you get horrible bone pain and people really suffer from it. And some patients tell me that their impact from this treatment is worse than their chemotherapy side effects. So what we are tending to find that if we use mistletoe in addition to it, we can reduce GCSF injections and the impact of those on quality of life by approximately anything between 1/3 to 2/3, which is a huge impact for the patient and enable them to continue on their treatment uninterrupted.
And do we know anything about whether mistletoe has any ability to actually inhibit disease and prolong life?
It's a good question. There's definitely been observational data. Studies have been done on non-small cell lung cancer in combination with immunotherapy. With colorectal cancer, we can see some improved impact in stages 1 to 3. There have been some other studies across pan-solid tumor types that again show an association with improved overall survival. Now, again, we do have some mechanistic data, preclinical data, when we step back to the lab, that mistletoe components can have apoptosis induction effects.
Which is cell death.
Exactly, cell death, absolutely. They can inhibit formation of new blood vessels, angiogenesis. They can potentially inhibit some of the pro-growth pathways. But what we don't know is how much of that contribution to overall survival is mistletoe's impact versus maintenance of standard of care treatment, enabling people to continue and get their full dose of standard of care. So that bit we don't know.
It's quite difficult to break down, isn't it, when you've got multiple factors involved in treatment?
Definitely. And I think it needs to be a very well-designed prospective study that will actually look at that. And it will probably have a translational arm really behind it to look at any of the biomarkers that might be changing for patients. I mean, the other thing that we need to investigate is actually, we know that some people respond to mistletoe therapy better than others. A little bit like immunotherapies, we know some people respond better. So we actually need to find out what might be the enabling factor. It could be something like the gut microbiome, like it is for immune checkpoint inhibitors. It could be about the systemic levels of inflammation, which we monitor and control really tightly for mistletoe therapy as well. So I think there's a lot of questions that we need to answer. But I guess what I don't have doubt about in terms of clinical practice is that it's a hugely valuable part of our toolkit that we should be able to offer patients. And if they understand the data and the pros and cons and risk and benefit, and they want to use it alongside standard oncological care, then why not?
So what exactly are the risks? I mean, you've touched on the potential inflammatory effects. Are there any other potential risks people should be aware of?
Yeah, so the allergy to any injectable medication is the first risk anyway. So we always supervise the first injection. So somebody will come to clinic or have a qualified nurse attend and supervise their first injection. But it's the same with a bee sting and any injectable, really. Second bit, yes, exacerbation of inflammation if you have existing autoimmune disease. Usually, again, we monitor that very carefully. The other bits and pieces that we could say is excessive local reaction. Again, it is a side effect. So if you over-inject a massive amount of mistletoe, then you definitely will get a big red itchy spot. So that will go over the course of a week or two, but that is a side effect. People have talked a little bit about, there was a question about hepatotoxicity or liver toxicity with mistletoe. Now, the worst study ever was done. So when they looked at it, they took the highest lectin mistletoe, the punchiest mistletoe you could possibly find. Imagine getting a drug and trying the top dose of this drug. And they gave it intravenously, which we never start with anyway in patients, at an extremely high dose, 2,000 milligrams of Helixor P to healthy volunteers. And all they could get was reversible hepatotoxicity. So yes, their liver enzymes popped up a bit and then they resolved in a couple of weeks' time. So when people tell me that mistletoe is hepatotoxic and they point to this study, I say, I'm never going to give a naive patient Helix-OP 2,000 milligrams IV. And it's completely not applicable to subcutaneous administration, which has much lower doses. When we look at hepatotoxicity, we're still always cautious. We monitor it as a part of our long-standing clinical audit. But so far, we have had no LFT elevations attributable to mistletoe over the 3 years we've been running a formal audit with mistletoe. So I would say that's a theoretical consideration, definitely something you should be monitoring for, but it is something that I genuinely do not see in clinical practice.
But what about a developing allergic reaction? Because sometimes people can tolerate something to begin with, and then over time they develop an allergy to it.
Yes, so it can happen. And I would say that's again where an experienced physician would be able to monitor it and keep an eye on that. And usually all of our patients get counseled what to do. They get given standard allergy counseling around keeping an antihistamine, all of the normal emergency procedures. Again, over the last however many years we've been prescribing mistletoe for well over 5-6 years now, formally as an audit. We have not seen that happen as an allergic reaction at home that was serious enough to warrant an admission. So usually what we get is you can kind of get this tickle of deteriorating tolerance, is how I'm going to describe that. People will say, I don't feel quite so well, in which case we can mistletoe type switch, actually. Because mistletoe types are so different in their composition, you can develop an antibody to a specific lectin. And so if I can switch you to a different kind of mistletoe that doesn't have that lectin, actually I can bypass that altogether.
And are there any medications that patients shouldn't take if they're using mistletoe therapy?
Absolutely. So we definitely find that we want to be stopping mistletoe therapy if somebody's prescribed high-dose steroids. And that's because the steroids in of themselves will knock out that immunomodulatory effect of mistletoe. So if somebody needs them for control of whatever condition they have, we would normally stop mistletoe so we're not wasting their time and money. And then we will restart when those steroids are tapered and people are no longer on high-dose steroids. And so sometimes people are not counseled around that itching reaction they can get with mistletoe. And they go, I'll just put a bit of steroid in it, or I just take something if they have it at home. So we should really be counseling people against that, because we don't want to be giving immunomodulation, immunostimulant support with one hand and then immunosuppressant with another hand. So it's an important confounding factor as well in mistletoe studies that people need to be aware of. We want to be able to use mistletoe alongside shorter, lower dose steroids. So, for example, for antiemetic control, anti-nausea, but we don't want the people to be on long-term high-dose steroids when they're having mistletoe therapy.
And in fact, some people have even questioned the use of steroids in cancer therapy, even if you're not on mistletoe.
Absolutely. And I think the tricky thing is that with steroids is I really don't like them being handed out to perk people up like sweets.
Because what you see somebody and they've been given steroids and superficially looks as if they're doing better.
But that's what we call it's a false overlay. What you will get is a drive without any real substance behind it. So people will crash. Effectively, if you discontinue steroids, they will crash and they will crash badly. And usually, because steroids are immunosuppressant, I question as to whether we should be using them like sweets in advanced disease anyway, but they also metabolically dysregulate you and have multiple pleiotropic effects, anything from osteoporosis to skin thinning to multiple different bits and pieces. So I think we should be just cautious. I think we should use them on license, for the desired lengths, but we should be using lowest doses for the shortest amount of time needed to control specific symptoms. I think there are far better things we can do to help patients' quality of life and fatigue in advanced cancer than just hand out steroids to perk people up until they crash.
Because if we want cancer patients to have a functioning immune system, a drug which basically suppresses that may not be the best thing for them.
No, exactly. And I think that sometimes it's necessary. So when we get these massive immune flares as immune-related adverse events in immunotherapy, we have to give steroids to control it because it's dangerous. But at that point, you'd want to be limiting that as well. You'd want to be trying to make sure you're giving, again, lowest dose, shortest course, and you really are monitoring that patient for the complications, because a lot of patients don't get told about the fact they're going to become sarcopenic pretty quickly, actually. That proximal muscle wasting is a massive problem for some of our older patients. They might already be struggling to get out of a chair. You give them some steroids, they might feel a bit more energy, but they can't get out of the chair to mobilize because you wasted their proximal muscles. So I think there's a lot more caution is needed around counseling people. And also, if you have to give people steroids, talk to them about mitigating their side effects. Talk to them about resistance training, making sure they have adequate protein intake, controlling their blood sugar well, get them to report the things that are going wrong for them, and actually consider really other alternative and complementary things that you can do that if it's not absolutely necessary that they have steroids.
So up to now, how many people would you say you've treated with mistletoe therapy?
Many, many, many. I mean, over our clinic now as well, we have several prescribers. So it used to be there was just me being a prescriber. We now have all of our integrative oncology physicians prescribe. So I'll be able to tell you that when we present the paper at SIO this October.
It would be over 100?
As a clinic, definitely over 100. Okay, me, myself personally, probably just under.
You talked about injecting it subcutaneously. So when would you use intravenously?
I mean, to be honest, it's been used in multiple different applications. So intravenously, they've actually used it for pleurodesis. That's the sticking together of the lung lining when people get effusions in those. They've used that in Germany and very successfully. They've used intrabladder instillations for recurrent bladder cancer. That's quite commonly practiced in Switzerland and Germany as an example. We tend to just stick to subcutaneous and intravenous use of label.
So when would you use intravenous?
So very much more with advanced cancers and rapidly progressive cancers. So if I looking at stage 4 advanced cancers, and ideally I would like to start with subcutaneous and then go to intravenous as an adjunctive method. Because intravenous uses higher doses, more expensive, and actually most patients can't get to you all the time for intravenous infusions, we tend to maintain them on a combination. So they'll come for some of the higher dose infusions and they will do subcutaneous at home in the meantime.
So the intravenous tends to be a more aggressive treatment.
Absolutely. And also it has a more cytotoxic effect. So as we know, if we're injecting subcutaneously, we're not going to have any direct cytotoxic effect because the absorption is going to be minimal systemically. From point of view, if we're injecting higher doses of mistletoe, then we are actually looking at viscotoxins in the mistletoe having a cytotoxic effect, not just an immunomodulatory effect. So it has quite a different effect.
Can you talk about some of your patients who've had mistletoe therapy, about how it's helped them?
You were there, the lecture that we talked about, and I think that patient always springs to mind for me. I think when we have people who undergo conventional care and they're really floored by their first cycle or two of conventional treatment, that particular patient had immunotherapy. And she really found that actually she couldn't cope very well with the first couple of cycles. There were nausea, fatigue, and other things. And she was like, well, this is not the quality of life I'd want on treatment. I'm not sure I'm going to be able to continue with that for months and months. And then as we studied mistletoe, actually, we could really see her quality of life transform. She's able to go out and do normal things the same day of infusion time. We're not getting those dips in energy. So I think that's one example. I mean, I have patients who've been maintained on mistletoe with metastatic disease for over 5 years, okay? And so they're with me, undergoing different lines of treatment, but they're still with me and they're still having vast majority of time a really good quality of life. And that's, I think, what we really want for patients with integrative oncology. I don't want more years. More years is great, but I want more years with good quality. I don't want people to have more years in bed. So I think that's really what patients tell me in general. If I think about that other patient, she's been on mistletoe for, I would say 6 years. And she's gone through all sorts of phases of treatment, anything from post-chemotherapy mop-up to now on targeted therapy. And she really credits her quality of life on through different lines of treatment to mistletoe. And she's been through different kinds because I changed it according to her parameters, how she was feeling, what kind of treatment she was on. And she says that enables me to be a mum, a wife. It enables me to have normal quality of life. And actually, if you met her in the street, you'd never know she had metastatic cancer. And actually, that's what we aim for our patients. For those of them who don't have hair-losing regimes and are easy to spot, we want you to be able to walk past our patient in the street and say, I had no idea they have metastatic cancer.
So again, there's a suggestion, and it's only obviously a suggestion because you don't have the data at this moment, that there might be some impact on prolonging life.
I think from my side, I'm observational data points to overall survival benefit in multiple different tumor types. We just don't have interventional data, and that's the bit we really need to get. But, the immunotherapy combination in terms of synergy effects, the recent real-world data study was incredible. So ESMO growth study for Helixor in combination with immune checkpoint inhibitors, you can just see those survival curves diverge massively.
Can you explain a little bit more detail what the study showed?
Sure. So this was looking at the real-world data of saying if you have Helixor in addition to your immune checkpoint inhibitor, so things like pembrolizumab, for example, it's a type of immunotherapy. If we have an addition of that, does it change overall survival? So when we do survival curves, we actually look at how patients survive over time. And if the survival curves diverge, so if they come apart, it means there's a survival benefit for a particular combination. So what we can see is a very much more clinically and statistically significant improvement in survival for advanced non-small cell lung cancer patients who have immunotherapy in combination with Helixor mistletoe. They've done other mistletoe analyses as well, actually. Really amazingly, if you're female, interesting enough, you respond even better. So if you're a female with advanced non-small cell lung cancer, your risk of dying is reduced by 91% with this combination.
Is that a relative or absolute change?
So it's relative, but as you can imagine, the risk of dying from non-small cell cancer in an advanced setting is pretty amazing. So
sure, it's not a cancer with a great survival rate, sadly.
No, not in stage 4. And that's what they were looking for. They were looking at that non-resectable advanced stage cancer. So in early resectable cancer, we actually don't see as much benefit, which is expected because actually we are going to finish treating those patients and they're going to go off into the survivorship side. So I think OS-wise, we have observational data that's really strong. We need to run a prospective trial. In clinical practice, do I think it makes a difference? I think it maintains my patients on treatment. How much of this contribution is pure mistletoe? How much of it is maintaining them on their different lines of therapy? I don't know. But I do know that for me, it makes a significant difference clinically.
And is there anywhere in the NHS offering mistletoe therapy?
Good question. So at different points, I understand that Camp Hill Wellbeing Trust in Scotland and the Royal London Hospital of Integrative Medicine used to offer it on the NHS. How much regulation they have now and what kind of mistletoe they offer, I don't know at the moment. And again, if you're looking at guideline-based mistletoe care, you really are looking at injectable mistletoe that's prescribed and monitored as an off-license medicine. It is not about drops or mistletoe tea or any other forms of mistletoe at all. So I think they would be the first port of call that you might want to consider. But again, because of the shifting regulations, something that might be available 1 year might not be available another year.
Does it frustrate you that this approach is largely available to people who can afford it? And do you see any way in which you could work with the NHS to enable more patients to benefit from this approach?
100%. Absolutely. I find it very frustrating. It's the reason why I get, companies who have to pay me honoraria to either donate to charities that are going to do some of this work or provide me with free products to give my patients so I don't have to worry about whether they can afford it or not. NCIO, the new National Centre for Integrative Oncology charity, of which I am CEO, is going to be absolutely doing this work. So we are in the process of establishing a clinical service that will provide funded mistletoe therapy. Now, can I promise it's going to be free for everybody? No, but it will be very heavily subsidized. And we're hoping that will open a route into the NHS to be able to collaborate and get referrals and also just get a bit of familiarity in the system, because I think a lot of the time what we don't know scares us. Once we actually get clinicians to understand the benefits it has, once they've seen their patients coming back to their maybe GP surgery or oncology setting saying, this is how it's impacted me, I think the culture shift will happen. And I think at that point, we will be starting to see more openness to this as a treatment.
If you could wave a magic wand, how would you like to see mistletoe therapy develop over the next decade or so?
Ooh, I have so many trial ideas. I tell you what, my strategic priority thinking about this, and actually it's very much not a magic one, but work in progress, I would say. My work in progress bit is there's specific targeted therapies which we know mistletoe can help with clinically. In our clinical practices, we all see it. So this is the CDK4/6 inhibitors that I've mentioned. For those drugs such as palbociclib, ribociclib, abemaciclib, those drugs can have a significant impact on those white cell counts. And that might prevent people from continuing this treatment or lose its effectiveness altogether. We don't have anything to give these patients right now, zero. We have zero options. We can't give them G-CSF, it doesn't work. So we have to either continue to reduce dose until it becomes ineffective or stop treatment and lose that line of treatment altogether. So actually, we're looking at the moment at doing both observational data in a phase 2 study in Mistletoe for cytopenias induced by CDK4/6 inhibitors. Immunotherapy work, I'd love to run a prospective randomized controlled trial because I think it needs to be done. And it needs to be done as a real world clinical practice. So some of the trials I see out there that have had tricky results, they usually do not mimic clinical practice. They provide one mistletoe type to all the patients regardless, and they stick to fixed dosing. It just doesn't work. That's not the way I use it in clinical practice, and therefore that's not the way I would want to do it. I'd like to run a kind of proper protocol adaptive trial that will mimic real world practice with immunotherapy. What my magic one bit will be is I would love the MHRA to acknowledge the fact that we do have enough evidence for it as a supportive care medication. I'd love it for it to be subcutaneously on license, and I'd love for it to be reimbursed by insurance and available on the NHS. That's a magic one bit.
Let's hope it happens. Absolutely fascinating talking to you today. Thank you so much, Nina.
Thank you, Liz. A pleasure to be here.
Goodbye.
Bye.
Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.